Hello and welcome to the Hughes Clues Stroke and Acute Intracranial Problems, finally, part 4 and the end. And I know that you're pretty much sick of neuro at this point. I'm going to zip through this and just pause the recording and read the slides if you want to kind of slow down on the information. So we go back to our 22-year-old construction worker who was diagnosed with a subarachnoid hemorrhage, and he becomes unconscious while displaying rapid tonic-clonic movements. So what might be occurring? Well, we figure that this patient who had an intracranial problem is at risk for having a seizure is now experiencing a seizure. And we know that the common term is convulsions, and we've got what they are. Seizures are episodes of abnormal motor, sensory, autonomic, or psychic activity that results from excessive discharge from cerebral brain. Cerebral neurons. A localized area or the whole brain can be involved, but the underlying cause of a seizure is an electrical disturbance in the nerve cells. In other words, just like in the heart, and the electrical activity must go from one cell to cell to cell, so too it must do so in the brain and with the nerve cells. And so, these cells can admit an abnormal, uncontrolled electrical discharges. And there's no way to restate this in any kind of fabulous way. So I've just basically copied and pasted what I think is important from Dr. Reed's notes. Now, there's pretty much a terminology here that seizures can either occur because of some kind of congenital disorder, and that's usually called then or termed as epilepsy, or it can happen in an acute problem, such as when a patient has a head injury or a subarachnoid hemorrhage or tumor, or any of the things. Now, also notice that seizures can be related to reversible conditions such as infections or electrolyte imbalances. So how are seizures diagnosed? Well, again, the diagnostic assessment is aimed at determining the type of seizure, their frequency, and severity. So what I've been seeing a lot lately is the EEG and telemetry. This is a video recording of the patient's activity because sometimes it's really difficult for physicians to identify what kind of motion or activity is the patient displaying when the seizure occurs. A lot of times you can't be in the room all the time, and so nurses will come in and then you might report that, hey, I think they had a seizure. Of course, they're going to do physical and neurologic evaluation. We got to make sure that all the lab values, sodium, and those kinds of things that markedly affect the nerve impulses in the brain are normal. And then, of course, there's an MRI, and this would be to rule out if it's not known whether this patient has some kind of physical problem, such as a tumor. Identify the nursing management for a patient at risk for or diagnosed with a seizure disorder. And this is really where you're going to be tested on, not only for Dr. Reed, but in your ATI exams and also in your NCLEX. So I've split it up into 3 different times or parts of when a seizure or a patient at risk for seizures. And again, just pause the video so that you can, or the recording so that you can kind of look at this. Most of these are really no-duh statements. You know this, but this is really what you're going to be tested on. So notice that you're going to do certain things when the patient's at risk, certain things when it's during a seizure, and then certain things during the postictal period, and that's the immediately after the cessation or stopping of the seizure. So what kind of complications can occur? Well, usually a seizure is self-limiting. In other words, it stops on its own, and most of us really don't have to do anything except protect the safety and manage the airway. But there can occur a time such as status epilepticus, and this is where you have acute prolonged seizure activity. And this is also why they do the telemetry video recording, because sometimes they don't and the EEG recording, because sometimes the seizures, it looks from the outside that the patient has stopped seizing, but in the inside with the electrical activity that the seizure is still occurring. So we do the EEG, and essentially if it's the seizures lasting longer than 30 minutes, then that's considered to be status epilepticus. According to Dr. Reed, the airway management and adequate oxygenation must be concomitantly provided. In other words, you got to make sure the patient's breathing and their airway and oxygenation is okay. And then you're going to have to do something to quickly stop the seizure. And that's why the diazepam or lorazepam, these are your benzodiazepines, could be given. And then some kind of anti-seizure medication, such such as fosphenytoin is given. So these, again, are very important to give so that the seizures can be immediately stopped. And then if this treatment doesn't work, then general anesthesia or short-acting barbiturate. Again, this is not going to be a nursing consideration. This is just going to be something that is going to be prescribed by the physician. That's the end of the seizures information. I've really summarized it very, very briefly. And then now we move on to the neuromuscular problems in the intracranial problem grouping, and that is Parkinson's disease. So what is Parkinson's disease? Well, it's a basal ganglia dysfunction that is caused by either some kind of genetic, viral, environmental toxin induced, or some of all of the above, or some we just don't know. But the bottom line is there's a depletion in dopamine. So let's go back to what the heck dopamine is. And whenever you have a nerve cell, the nerve cell is going to, it has to have the work. And when the work is there, then acetylcholine moves from nerve cell to nerve cell. That's the neurotransmitter that gets the cell working. And then I call acetylcholine the accelerator. It moves the transmission downstream from nerve cell to nerve cell. And then dopamine is like the brakes. And as you drive your car, you know that acetylcholine is the accelerator, and so it will cause the movement, and then dopamine is the brakes that slows it down. And in a good driving habit, you would want this to be a smooth movement and then slow. Well, the problem with Parkinson's disease is there is a decrease in dopamine, and because there is less braking of neuroactivity, the nerve cell activity, neuron activity, then what happens is the acetylcholine or the cholinergic or the excitatory effect is what is seen. And so that's what gives rise to the signs and symptoms of an individual who has Parkinson's disease. And these are related into hypertonia, which is rigidity, and dyskinesia, which is a movement disorder. So I've got the signs and symptoms that are listed on the next slide. And as you look at them, I want you to think about, well, what do these signs and symptoms or the problems that occur with Parkinson's disease, what do they mean to me, the nurse, as opposed to what kind of nursing measures? And when you think about dysarthria, which is difficulty speaking, and dysphagia, which would be difficulty swallowing and drooling, you should think about airway management. So that's pretty much the key to this kind of problem. Okay, sure, there's postural hypotension, gastric and urinary retention, constipation, and all of those other things that are listed on there. But whenever you see a problem with dysarthria, speaking, and swallowing, your first thought should be airway management. So what nursing measures, what nursing measures are indicated for the management of the patient with Parkinson's disease? So we talk about, again, we've already talked about airway management, their effectual breathing, because if they're ineffectual in breathing, then they can have CO2 retention. Postural hypotension gets the patient with blood pressure, that C circulation, and of course, because their movement ability is very rigid and jerky and they have dyskinesias, they're at risk for following. So again, see Dr. Reed's lecture notes. And then the last thing that I'm going to just mention about is that there are other neuromuscular problems, and that's the ALS, Guillain-Barré, and myasthenia gravis. Again, there's so much information for exam one. What should your focus be? Anytime you have a patient with a neuromuscular issue, you always have to manage and assess the airway, the breathing, and so those are A and B, so they fall in a very high priority zone. I hope this has been helpful. If you have any questions, email me.